Hi, this is Dr. Max Fung, University of California, Davis in Sacramento, California. This session will focus on vasculitis and related disorders such as vasculopathy under the broader heading of inflammatory vascular diseases. And in these opening seconds, while you are hopefully still paying very close attention, I'd like to start rather than end this presentation with a brief acknowledgement to a few colleagues who have helped me along the way with vasculitis. Now, there are many national and international experts with vasculitis, but I'd like to personally thank Drs. Carlson, Dr. Chen, and Dr. Lee, not only for their publications on this subject, but also for helpful discussions over the past several years. So, vasculitis. From the perspective of a dermatopathologist, what are the minimal diagnostic criteria? Well, it's an itis, so we can expect that there will be perivascular inflammatory cells, just like with every other form of itis. In the vast majority of instances in vasculitis, those cells include neutrophils. But more specifically, we need to see leukocytoclasis, or nuclear dust, which in the spectrum of ways that cells can die is related to karyorrhexis, characterized by nuclear fragmentation. But as you can see here, with classic descriptions of karyorrhexis, it's describing nuclei within a cell. Whereas in vasculitis, we're usually referring to nuclear dust outside the cell. Damage to the vessel wall is additionally reflected by the presence of extravasated erythrocytes, or extravascular red blood cells. And so in practice, I tend to regard these three as the minimal diagnostic criteria for vasculitis. However, there's a fourth histopathologic feature that we like to see in vasculitis, but it tends to be the hardest one to find. So I would say at this point, this would be, and I'm sorry to bring you back to the nightmare reality of high school or college, but this would be a C. This would be 3 out of 4 criteria, 75%. In order to seal the diagnostic deal on vasculitis, we need to see fibrin within and around the walls of the affected vessels. That would then be an A, or A+, 100%. When reading about diagnostic criteria for vasculitis or listening to or speaking with others, other criteria are listed, but in my experience, they're not as helpful. One of them is expansion of the vessel wall, and that can take at least 2 guises in my experience. One of them is endothelial cell swelling, which is enlargement of the endothelial cells lining the affected vessels. And first of all, I think that's fairly subjective. And secondly, I find that that finding, if present, is invariably present in conjunction with the other 3 or 4 essential criteria. The other way that the vessel wall can be expanded is in chronic vasculitis, when you can get a fibrointimal thickening of the affected vessel. And again, that usually is present in conjunction with additional features of vasculitis. Another feature is vascular necrosis, and so that certainly makes sense that inflammation directed against and damaging the vessel wall will eventuate in endothelial cell necrosis. But in my experience, this is pretty difficult to identify, and if it's surely present, then in my experience, it's also surely present in conjunction with other histopathologic features. So for example, here's a vessel. I can kind of make out the outline, but it's far from normal, very damaged, very eosinophilic. I see smudgy eosinophilic material here. Is that fibrin? Is that a necrotic endothelial cell? I can't tell. I don't think it matters. In contrast, the eosinophilia of epidermal necrosis is more readily identified, where we have loss of the nuclear basophilia. But I think probably the biggest clue here is that the tissue architecture is more or less retained, where in vasculitis, the vessel wall can be completely obliterated. Having been engaged in the full-time practice of academic dermatology and dermatopathology for now 25 years and going, I think I'm somewhat set in my ways. But for vasculitis, I feel like I've still more or less been able to get away with what I was taught when I was a resident, which is a pretty short list of vasculitis. So this is certainly not a complete classification, but this is a list that I think gets you through as a dermatopathologist. So we have our small vessel vasculitis, which we typically refer to as LCV, and no doubt that has a very long differential diagnosis, but it's a differential diagnosis that the pathologist cannot resolve. That's more on the clinician side to do that. And of note, the differential diagnosis for LCV, small vessel LCV, does include more forms of ANCA-associated systemic vasculitis that we tend to classify as medium, or sometimes for some people even large vessel vasculitis, but in fact it's usually small to medium vessels that are involved. Now there's a couple unique flavors of chronic small vessel LCV, granuloma faciale and erythema elevatum diutinum. We'll take a brief look at those. And then we have our true medium vessel vasculitis, which again some people will refer to as large vessels. But in the spectrum of the human body, including the aorta, there are no large vessels in the skin. So this is a medium vessel vasculitis, large for the skin, medium for the body. But polyarteritis nodosa, specifically the skin-limited variant that we have referred to as cutaneous PAN, and now in the revised Chapel Hill nomenclature is cutaneous arteritis, is truly a medium vessel vasculitis, typically involving small arteries. And then again, we have our GPA and EGPA, sometimes characteristically, but not always involving medium vessels. So this short list has pretty much gotten me through. So a small vessel LCV with a long differential, that's more for the clinicians to resolve. A couple little unique flavors, that's for the dermatopathologist to resolve. And then basically a big three larger vessel vasculitis that each have their own distinctive clinical and histopathologic features. The revised International Chapel Hill Consensus Conference on Vasculitis is now slightly over 10 years old. And although some authorities will refer to this revised Chapel Hill as a classification system, the authors of the papers emphasize that this was not a classification system nor diagnostic criteria, but rather a nomenclature system that over the past decade has served as the basis or foundation for other organizations' efforts in developing diagnostic criteria, such as the ACR-EULAR, American College of Rheumatology, and European Alliance of Associations of Rheumatology, diagnostic criteria for ANCA-associated vasculitis, or smaller focus groups such as this, focusing on aspects of cutaneous vasculitis. So we should take at least a brief glance at this foundational nomenclature. Starting with small vessel vasculitis, we have IgA vasculitis, or HSP, cryoglobulins, urticarial vasculitis. These are considered immune complex mediated vasculitides, so DIF, direct immunofluorescence testing, does have an important, if not essential, role in establishing the diagnosis in these cases. Whereas in contrast, the other entities listed here are considered ANCA-associated, anti-neutrophil cytoplasmic antibody-mediated forms of vasculitis. And so they can involve larger, medium-sized arteries and veins, but most commonly actually present as a small vessel LCV. So it's part of that dermatopathologist long differential diagnosis, so GPA and EGPA. And microscopic polyangiitis, I'm not going to be discussing further in this session, but it does present as a small vessel neutrophilic leukocytoclastic vasculitis. Medium vessel vasculitis includes polyarteritis nodosa and Kawasaki disease. We'll only be discussing cutaneous polyarteritis nodosa in this session. The true forms of large vessel vasculitis include giant cell arteritis and Takayasu arteritis. Not surprisingly, not really relevant to dermatopathology, with the rare exception that giant cell arteritis or temporal arteritis may rarely exhibit cutaneous involvement as part of that systemic vasculitis. And while the new nomenclature has been readily adopted by experts discussing and publishing on vasculitis, some terms have, in my experience, not really gained traction on the front lines. So for example, on essentially a daily basis, I see pathology requisitions that simply say rule out LCV or rule out PAN, and that's much more telegraphic and effective and safe, I think, than trying to introduce one of the new terms. Some people who are not in the field will simply just be confused by these terms, but perhaps it's just a matter of time. And while the revised nomenclature saw a significant appropriate push towards a more disease and etiology-based classification, the changes have had little impact on the day-to-day practice of dermatopathologists. All of these entities have always been part of the long differential diagnosis of leukocytoclastic vasculitis. So let's take a look at some examples of leukocytoclastic vasculitis, or LCV, which is by far the most commonly encountered form of vasculitis. And we're talking about vasculitis that's focused on small vessels, specifically postcapillary venules in the upper dermis, typically appearing at scanning magnification as a superficial perivascular and interstitial infiltrate. Extravasated erythrocytes, if prominent, will impart a somewhat reddish hue to the infiltrate even from the panoramic view, but invariably will be present at higher magnification. In concert with extravascular neutrophils and neutrophil nuclear fragments, leukocytoclastic nuclear debris, or nuclear dust. Vascular fibrin, if subtle, can be the most difficult feature to identify. Do you see it here? At first glance, it may appear indistinguishable from surrounding dermal collagen, but it typically has a slightly more intensely eosinophilic appearance, a slightly more smudgy or homogeneous rather than fibrillary quality, and it's invariably present within and around vessel walls. So in this example, I see it circumferentially around a portion of this small vessel, the lumen of which is outlined approximately with a yellow dotted line. Here's another example with a perivascular and interstitial infiltrate at scanning magnification. On closer examination, some extravasated erythrocytes are apparent, with some nuclear dust, but no overt vascular fibrin. So at this juncture, 75%, or letter grade C, which in my experience is sufficient to issue a pathology report with a line diagnosis of consistent with or compatible with leukocytoclastic vasculitis in the appropriate clinical setting. And in some cases, some diligent pathologists with diligent scrutiny, sometimes additional deeper sections, may find occasional foci of vascular fibrin. While it seems to be that the vast majority of LCV is immune complex mediated, one of the potential pitfalls is related to the fact that the immune complex formation is relatively acute and transient, so that standard teaching is to biopsy the earliest possible lesion, ideally less than 24 hours old. But of course, in practice, that's not always possible. So one of the pitfalls is that with fully developed or somewhat well-established lesions of LCV, the direct immunofluorescence is sometimes negative, so it's essentially a false negative result. Here's one such example that's really kind of a slam dunk at the level of H&E for vasculitis. With perivascular neutrophils, nuclear dust, extravasated red blood cells, and pretty prominent or florid perivascular fibrin around most of the vessels. But in a case like this, I might almost expect the companion direct immunofluorescence study to be negative, a false negative result. In some examples of florid LCV, prominent extravascular neutrophils can migrate up towards and into the overlying epidermis, mimicking other immunobullous disorders such as dermatitis herpetiformis, with neutrophils collecting within dermal papillae and with overlying neutrophilic spongiosis. The additional presence of eosinophils can evoke consideration of other subepidermal blistering disorders such as bullous pemphigoid. But remember, immunobullous disorders usually have the inflammation centered around the location of the antigen target. So typically, as in pemphigoid, the dermal epidermal junction, we don't usually see deep dermal perivascular and perivascular inflammation in immunobullous disorders, but we do often in LCV. So there's a potential for getting distracted by all the action happening around the epidermis and missing the diagnostic changes of vasculitis in the underlying dermis. So I think the first way out of the trap is simply to be aware of the fact that leukocytoclastic vasculitis can cause a fairly wide variety of secondary overlying changes that mimic immunobolus disorders with neutrophils. And then secondly, to make sure you look at the underlying blood vessels and hopefully, in most cases, see the diagnostic changes of LCV that are not a feature of any immunobolus disorder. Sometimes subtle, yet present. In the event of such a case being submitted as a superficial shave biopsy, the distinction by H&E may be impossible, and most likely one would best be saved by the clinical correlation, which more often than not will be palpable purpura rather than itchy papullovesicles on the elbows and buttocks or large blisters. Now, on the sparse end of the histopathologic spectrum of LCV, changes might not even get a letter grade C. They might basically fail. So in a case like this, I see a lot of hemorrhage with background solar elastosis and some nice intact small postcapillary venules. So this looks like solar purpura. So I was surprised when the companion DIF was positive for vasculitis. I then looked at the clinical history, and the patient had a pre-existing diagnosis of recurrent LCV. And I went back and pulled a previous biopsy, and this is what it looked like. More classic changes with definitely a passing grade. So the long differential diagnosis for LCV is too long to fit on one slide. My experience actually is that clinicians don't really need it. So rather than cluttering up the pathology report with a long list, usually a diagnosis of LCV suffices. And then if the clinician has a specific question to address, that can be addressed. But just the long boilerplate is usually not needed. But just for the purposes of review, the many different causes in the long differential can be kind of put into various buckets. So we have idiopathic, which is actually a big category, IgA vasculitis, which is actually fairly common in my experience. So we'll talk a little bit more about that. Of course, drug, connective tissue disease, various infections. Don't forget exercise-induced vasculitis. And then there's the somewhat notoriously difficult to diagnose urticarial vasculitis, and then the rare but distinctive cryoglobulinemia. IgA vasculitis, historically known as Henoch-Schönlein purpura, HSP, is one of the most commonly encountered forms of vasculitis, at least in my practice. So HSP is the original historical designation for vasculitis presenting with GI symptoms and evidence of renal involvement. And although historically a pediatric disorder, it's well recognized that it occurs in adults as well. And direct immunofluorescence is expected to show granular deposition of IgA in the superficial vessels. So here's an image of DIF testing with IgA, and the dermal epidermal junction is somewhere up here. This is probably an example of that's positive, but it doesn't show up very well. It's kind of smudgy. What we'd like to see is this dot-like or granular pattern in a more or less a ring shape in small vessels in the upper dermis. And one additional example of IgA vasculitis recently published by Peter Young and colleagues out of Kaiser Sacramento. Remember that when doing direct immunofluorescence testing, one must obtain usually a second biopsy, or else one could potentially divide a single biopsy and place that tissue for DIF testing not in formalin, but in Mischel's solution, an ammonium sulfate solution that preserves the immune complexes. And this is essential to establish a diagnosis of IgA vasculitis, but the DIF testing can support a diagnosis of vasculitis when other means are insufficient. So for example, if the routine biopsy was non-diagnostic, having a positive DIF could support a diagnosis of vasculitis. As a practical matter, we'd like to see a ring-shaped granular deposition of the immunoreactant in order to count it as real. And there shouldn't just be one. So having C3 or fibrinogen alone is not diagnostic. If the clinician is looking for vasculitis, it could be regarded as at most suggestive, but we'd like to see at least 2 reactants and ideally at least 1 immunoglobulin. Rheumatoid vasculitis is a potentially serious form of LCV that fortunately only affects a minority of patients with chronic RA. It tends to involve deeper dermal or subcutaneous vessels, and any organ system can be involved. It's immune complex mediated, so DIF tends to be positive. A relatively broad spectrum of vasculopathic changes have been documented in RA patients, ranging from non-inflammatory thrombosis to reactive angioendotheliomatosis, folliculitis, lymphocytic or granulomatous vasculitis, but the classic changes in rheumatoid vasculitis are a neutrophilic LCV involving deep vessels with prominent fibrin thrombi and endothelial necrosis, creating a profile of necrotizing vasculitis. On the sparse end of the histopathologic LCV spectrum is urticarial vasculitis, which, in contrast to the classic palpable purpura on the lower extremities that characterizes most forms of LCV, urticarial vasculitis can occur on any site and so often has a predilection for sites that you would not normally think about for vasculitis, so the trunk or even the face. Urticarial lesions tend to persist and leave hyperpigmentation, and on pathology it tends to look like a classic LCV, but I often describe it as being somewhat half-baked in that we don't usually see all of the features that we want to see, and changes tend to be subtle. Laboratory evaluation can be critical, assessing complement values, and the DIF findings, although this is immune complex mediated, the findings do tend to be variable, and diagnostic sensitivity is relatively low. Thus, establishing the diagnosis can be somewhat challenging. So it can be stated that the histologic criteria are the same as for any other LCV, but just less rigorous, and that we don't get to that C grade even as often as we'd like. So we might only have 1 or 2 of these classic 4 criteria that we'd like to find, and it may take multiple biopsies before getting a classic biopsy, or it might require a composite assessment of a couple of half-baked biopsies, a half-baked DIF, and clinical correlation along with laboratory investigation to establish a diagnosis of urticarial vasculitis. And so here we have a couple of, if you will, par for the course histologic examples of clinically confirmed urticarial vasculitis. On the left, we have extravasated erythrocytes and sparse neutrophils, but no nuclear dust or fibrin. And on the right, sparse neutrophils and nuclear dust, but no extravasated red blood cells or fibrin. Okay, on to a new topic, trainees, evaluate and interpret. Pausing for a moment, if needed, to evaluate these images whose diagnosis is deserving of dignity. And as a somewhat less esoteric hint, there is a misnomer involved. Granuloma faciale, characterized by usually a solitary erythematous papule or plaque on the face of an adult. Histologically quite distinctive, with a relatively dense mixed infiltrate that, despite its density, characteristically spares the immediate subepithelial zone, forming a Gren zone, and classified pathogenetically as a chronic form of LCV. A diagnosis deserving of dignity and also quite satisfying for the dermatopathologist. And a complete misnomer histologically in that the disease is not characterized by granulomatous inflammation at all. In this case, the term granuloma in granuloma faciale refers to the clinical appearance resembling other truly granulomatous disorders. So in a way, this is kind of a vestige that has stood the test of time, a vestige of the more of a pre-dermpath era in which disorders were named primarily clinically, such as pyogenic granuloma. So once again, there is no granulomatous inflammation in granuloma faciale. Very characteristic, however, is the profile from scanning magnification with a dense mixed inflammatory infiltrate, with a zone of subepidermal sparing or Grenz zone. That includes adnexal epithelium, such as the sweat duct shown here. And within the dense mixed infiltrate, variable changes of leukocytoclastic vasculitis are seen, including perivascular fibrin, in concert with neutrophils and nuclear dust, but all of this is amidst a mixed infiltrate with eosinophils and plasma cells. And histiocytes are certainly present, they're just not forming granulomas. So this is a true full house inflammatory infiltrate. Next up, trainees, please pause, interpret, and diagnose. This nodular eruption on the feet, knees, and dorsal surface of the hands of an HIV-positive man. Erythema elevatum diutinum, EED, is the other unique or special form of chronic cutaneous LCV. In the early stages, it shows the conventional features, and in the late stage, even more so than for granuloma faciale, EED is characterized by a prominent patterned lamellar fibrosis in concert with residual changes of LCV. Another unique feature of EED is the presence of cholesterol clefts occasionally, such that the old historical name for this entity was extracellular cholesterolosis, although subsequent studies have shown that the cholesterol clefts are actually intracellular. Scattered neutrophils amidst patterned or lamellar fibrosis characterize the entirety of this nodular lesion, with occasional foci more recognizable as conventional LCV with nuclear dust and variable fibrin. And one additional case from my former attending, Dr. Timothy McCalmont, courtesy of our mutual participation in the 2003 ASDP self-assessment course. The panoramic view showing the characteristic acral or acral type location, and beautiful patterned lamellar fibrosis with multiple neutrophilic foci. Okay, let's look at a larger vessel vasculitis, or more specifically, a medium vessel vasculitis, polyarteritis nodosa, PAN. In the revised nomenclature, PAN is reserved for idiopathic systemic vasculitis. In dermatopathology, it seems the vast majority of cases we encounter are indeed skin-limited, formerly cutaneous polyarteritis nodosa, now designated cutaneous arteritis in the Chapel Hill nomenclature. And at scanning magnification, these biopsies tend to show a mostly septal subcutaneous pattern of inflammation, since the subcutaneous arteries are limited to the subcutaneous septa. Classically, a neutrophilic arteritis with relatively circumscribed inflammation around the affected vessel. With chronicity, the profile of the inflammatory infiltrate evolves from neutrophils in early lesions to lymphocytic or granulomatous vasculitis in later lesions. And the lymphocytic stage is particularly clinically relevant in that the histology alone may be indistinguishable from other similar or related entities such as lymphocytic thrombophilic arteritis and macular lymphocytic arteritis, which some authorities equate as synonymous and in turn potentially synonymous with the sparse or mild end of the spectrum of cutaneous arteritis or cutaneous PAN. Of note, the minimal diagnostic criteria for vasculitis affecting a muscular walled vessel, such as an artery or muscular walled vein, is somewhat less strict in that the mere presence of intact inflammatory cells within the vessel wall has been regarded to be sufficient for interpretation as vasculitis, the thinking being that the muscular walled vessels would not normally allow the passage of inflammatory cells unless the vessel wall was damaged. So once again, we have a fairly circumscribed inflammatory infiltrate surrounding the affected small artery. And notice that in these two recut sections of the same affected small artery, the profile of the artery is different. One is circular on the right, and the other on the left is more oval in shape, with ideal cross-sections showing a circular profile of the rigid arterial wall and associated circumscribed or tightly cuffed infiltrate, perhaps best appreciated at scanning magnification. I know at least one colleague who would compare the appearance of this affected vessel to that of a strawberry donut, usually associated in PAN with at least some neutrophils, and in long-standing lesions, a greater proportion of lymphocytes and histiocytes. With vasculitis affecting larger vessels, such as the medium vessel vasculitis in PAN, the distinction between artery and muscular walled vein can become more diagnostically critical. And some textbooks will tell you that arteries are more round and veins tend to be oval. But as I just showed you, that's not always true because it assumes an ideal cross-section, which we basically can never assume. Both small arteries and small veins are defined as having a diameter between 1/10 of a millimeter and 1 millimeter. Arteries have a compact muscular wall with a prominent internal elastic lamina, whereas muscular walled veins have multiple thinner smooth muscle fascicles demarcated by thin elastic fibers and lack a prominent internal elastic lamina. I tend not to resort to elastic tissue stains, but rather just try to make the call on H&E. But I don't rely on a distinction between circular and oval, but rather a distinction between the profile of a smooth versus undulating vessel. And the analogy that I have is that of the old slinky toy, which is a rigid circular but flexible tube, kind of like that of a vessel. So if you imagine, you can take certain tangential sections through the edge of a slinky toy, and even though the vessel is circular, it's going to look oval. So rather than focusing on that, look at the irregularity of the profile of the vessel wall, and that will distinguish an artery from a vein in most cases in my experience. Of course, these are arteries and veins in the physiologic state. We're only evaluating vasculitis, in which case not only can the architecture of the vessel wall be obscured or completely obliterated, but even the pattern of fibrin deposition within and around the vessel wall can be misleading, as shown in this article from Dr. Carlson, showing a very irregular pattern of fibrin deposition, yet as best as we can still appreciate, the overall profile of these small arteries are circular. Erythema induratum is often limited to discussions of paniculitis, but is also known as nodular vasculitis. And to boot, it's a variable vessel vasculitis in that it can involve both larger arteries and veins, but most commonly involves the central lobular venules of the subcutaneous fat. In contrast to PAN, the inflammatory infiltrate in erythema induratum extends well beyond the affected vessels and into surrounding subcutaneous fat lobules, creating a significant and sometimes predominant component of lobular paniculitis. Eosinophilic granulomatosis with polyangiitis, or EGPA, formerly Churg-Strauss, is primarily diagnosed by clinical criteria with asthma, peripheral eosinophilia, and positive ANCA serologies, but the skin is frequently involved, although the clinical presentation and corresponding histologic features can be quite variable. So in the end, skin biopsy is desirable but not ultimately required for diagnosis. And as would be expected for all of the ANCA-associated systemic vasculitides, direct immunofluorescence testing does not have a role, findings usually negative or minimal. On biopsies, the presence of extravascular eosinophils are the only requisite finding, but a variety of other findings can be present and are somewhat more distinctive. So in the Chapel Hill, EGPA is actually classified as a small vessel vasculitis, but in reality the full spectrum is that of a small to medium vessel vasculitis, although small vessel LCV is regarded to be the most common manifestation. In addition, there may be extravascular eosinophil-rich granulomas with necrobiotic collagen, historically known as allergic granulomas. And additional ancillary histopathologic features that are not very sensitive, but if present, might appropriately trigger suspicion for EGPA would include the presence of flame figures, as well as marked papillary dermal edema. So a most typical presentation would be a small vessel vasculitis with prominent eosinophils. And if we're fortunate, we might appreciate extravascular granulomas, which can be fairly poorly defined and vaguely palisaded surrounding altered or necrobiotic collagen fibers. Granulomatosis with polyangiitis, GPA, is another ANCA-associated systemic vasculitis with variable cutaneous and corresponding histopathologic findings. As with EGPA, small vessel LCV is the most common manifestation, although the full histopathologic spectrum includes vasculitis of larger, medium-sized veins and arteries, including granulomatous vasculitis. And of note, the pediatric subset of GPA is notable for a clinically distinctive presentation as acneiform papules on the face. Credit should go to Dr. Lawrence Gibson and colleagues at the Mayo Clinic in Rochester, Minnesota, for publishing a lot of the large series on GPA, again confirming that small vessel LCV is the most common cutaneous manifestation. Therefore, it deserves a place in that long differential diagnosis of LCV encountered by the dermatopathologist, but the full spectrum includes other findings that, in my mind, are essentially those of EGPA if you subtract out all the, if you will, eosinophil-specific features of EGPA. So if you take away the requirement for eosinophils and you take away the requirement for asthma and peripheral eosinophilia, the rest of the findings are compatible with those of GPA as well. In this example, there is a relatively intense inflammatory infiltrate consistent with a necrotizing vasculitis with secondary ulceration, with relatively prominent histiocytes seeming to push aside the smaller neutrophils at the periphery. In my limited experience, I have found that the combination of small vessel leukocytoclastic vasculitis involving the face to be quite distinctive for GPA. At higher magnification, the histopathologic features are that of a conventional LCV, except that the biopsy has been obtained from the hair-bearing skin of the face. And in contrast to most examples of LCV, there is extension into the deep dermis and even superficial subcutis, as is generally more typical of the various forms of systemic vasculitis, such as the example of rheumatoid vasculitis that we previously reviewed, with very prominent fibrin consistent with a necrotizing vasculitis. Giant cell arteritis is officially a large vessel vasculitis. After all, the inflammation is directed against the superficial temporal artery, which is derived from the external carotid artery. In this clinically confirmed example, courtesy Dr. Errol Craig, the biopsy shows an arteritis in the subcutis, somewhat similar to that seen in PAN, but with a more poorly circumscribed periarterial infiltrate. That in this particular example is somewhat mixed with scattered neutrophils, eosinophils, lymphocytes, and histiocytes. Not quite yet overtly granulomatous, although granulomatous vasculitis is a characteristic feature in giant cell arteritis. The overlying skin in this biopsy shows solar elastosis, reminding me of a prevalent hypothesis from my residency days, suggesting a common denominator in actinically damaged elastic tissue in the pathogenesis of giant cell arteritis, as well as pinguecula of the conjunctiva and actinic granuloma of the skin. However, I haven't really heard anything about that hypothesis in the past few decades. Takayasu arteritis is the other bona fide Chapel Hill large vessel vasculitis, and the diagnostic criteria are essentially beyond dermpath. with no recognized aspects of its clinical pathologic spectrum primarily involving the skin. The concept of lymphocytic vasculitis is lesser known, but minimal diagnostic criteria include the usual histopathologic features of LCV, but without intact neutrophils. The differential diagnosis is somewhat diverse, but at the same time somewhat distinctive. So in my mind, when I see lymphocytic vasculitis, various things come up, and the list is so diverse that certain entities can just outright be excluded depending on the clinical setting of the particular case. But perniosis is one to think about, pigmented purpura, polymorphous light, pityriasis lichenoides, and interestingly, rickettsial and viral infections. And here's a reference for those interested in a deeper dive into this topic. Here's a biopsy of perniosis with its characteristic moderately dense, slightly bottom-heavy perivascular and periadnexal lymphocytic infiltrate on acral skin, with vessel walls variably obscured by the dense lymphocytic infiltrate, in concert with nuclear dust, but without intact neutrophils. And one more example with the characteristic marked papillary dermal edema and deep dermal perivascular lymphocytes, with extravasated erythrocytes and limited nuclear dust, but lacking intact neutrophils. Here we have vascular fibrin in drug-induced lymphocytic vasculitis, associated with lymphocytes and nuclear dust, but without intact neutrophils. Some people who know me know that I never like to forget about those eosinophils at the microscope, even if they are associated with connective tissue disease. So I'm going to close out the section on vasculitis proper by mentioning a couple rare variants of eosinophilic vasculitis. And so this is once you've excluded EGPA from your differential diagnosis and excluded a drug reaction, one can consider recurrent cutaneous eosinophilic vasculitis, which is usually limited to the skin and not associated with systemic disease, or you can consider eosinophilic vasculitis associated with a connective tissue disease such as lupus. And consistent with systemic vasculitis in general and the example of rheumatoid vasculitis that we discussed, this variant of vasculitis associated with connective tissue disease is often necrotizing. Vasculopathy is a relatively broad category referring to various disorders that involve and affect blood vessels but are not vasculitis proper. And they can be broadly categorized into various causes of vascular compromise. Calciphylaxis often has a special category in and of itself, but otherwise there's a very broad, long list of coagulopathies, also various embolic phenomenon, sepsis with angioinvasive pathogens, and then under the heading of pseudovasculitis, Carlson and Chen have also included nonspecific purpura, which can clinically and histologically mimic vasculitis, but is actually not affecting the vessels at all, either inflammatory or otherwise. More recently, Mar Llamas Velasco from Madrid, Spain, and colleagues have produced a detailed review of vasculopathy under the heading of occlusive non-vasculitic vasculopathy, which is a longer but more explanatory term that essentially comprises, in my mind, all of vasculopathy. So we see the same categories that have been listed under pseudovasculitis and vasculopathy by others, but this is a very detailed list that can come in handy when encountering such a case and needing to generate a complete differential diagnosis. I also recently saw a program in which Dr. Philip Lebois from San Francisco was scheduled to give a lecture called Vasculitis and Paravasculitis. And so that term kind of caught my fancy, and it was very much in keeping with the legendary lecture titles that Phil is known for. But that to me seemed a very appropriate term as well, because in addition to occlusive vasculopathy, it's often traditional to include other vascular disorders, specifically neutrophilic dermatoses. And so that's actually what I'm planning to discuss in the rest of this session, and that can fall under the broader heading of inflammatory vascular disorders, but more concisely, paravasculitis. But let's deal first with the vasculopathies that are occlusive and non-inflammatory. I'm using heparin necrosis as an example that's fairly prototypical for most of the entities on the long list. So short of actually seeing a distinctive embolus, you can't really go much farther than just saying vascular thrombosis. Sometimes with severe thrombosis and secondary ischemic necrosis, there will be ischemic changes distal to the occluded vessels, including subepidermal clefting with loss of epidermal nuclear basophilia, not seen in this section, however. The ANCA-associated vasculitis or vasculopathy of levamisole is clinically distinctive with necrosis on the ears and history of crack cocaine use, and the histopathologic spectrum spans that of a non-inflammatory thrombosis to inflammatory vasculitis. The profile at scanning magnification may resemble other forms of cutaneous vasculitis, but with relatively sparse inflammation, somewhat reminiscent of the profile that may be seen in septic vasculitis. Essentially fulfilling the histologic criteria for vasculitis, albeit with relatively small numbers of cells and relatively prominent thrombosis, occluding vascular lumina, with prominent fibrin and presumed endothelial necrosis in a profile of necrotizing vasculitis. And the changes can be somewhat focal, with occluded vessels juxtaposed against either adjacent or other sections of the same vessel, apparently unaffected, thrombosed. Calciphylaxis is a non-vasculitic occlusive vasculopathy characterized by the additional presence of vascular calcification that is typically centered within the subcutis and can range from prominent to subtle or absent, especially in limited samplings. Fortunately, not the case in this biopsy. Calcification is typically vascular, but may additionally be extravascular, the vascular calcification being far more specific. Nevertheless, in the proper clinical setting, the presence of extravascular calcification alone represents a clue to the possibility of vascular calcification elsewhere. Calcification of capillaries is more diagnostically specific than calcification of larger vessels, which could potentially represent a background finding. Calcification of capillaries in conjunction with small vessel thrombosis is felt to confer the greatest diagnostic specificity for calciphylaxis. As with any significant vasculopathy, there may be secondary ischemic necrosis, manifest histologically by subepidermal clefting and confluent epidermal necrosis with loss of the keratinocyte nuclear basophilia amidst a pristine, intact basket weave orthokeratotic stratum corneum. Concomitant with the recognition of the importance of identifying capillary calcification as a clue to the diagnosis of calciphylaxis, the calcium stain, von Casa, has gained importance to marginally increase the diagnostic sensitivity of capillary calcification, as a silver-based stain very clearly highlighting the capillary vessels black, revealing even the subtlest capillary microcalcifications. In serial recut sections, one can examine small thrombosed blood vessels lacking overt calcification on H&E, but with the von Casa stain marginally but critically enhancing the ability to identify calcification in the same thrombosed vessel. Cholesterol embolus is characterized by intraluminal cholesterol clefts. These are empty sheath-like or slit-like spaces where the triglycerides used to be. These are the same cholesterol clefts that I described but failed to demonstrate in extracellular cholesterolosis, now known as erythema elevatum diutinum, and this is all in a non-inflammatory setting, which has a tendency to look somewhat normal or unremarkable at scanning magnification. And as is typical with very focal findings, they can be difficult or impossible to find, sometimes requiring deeper sections, and even the appearance or profile in serial recut sections can look different. Recut number 2. And recut number 3. Short of subepidermal clefting with confluent epidermal necrosis, more subtle ischemic necrosis may be reflected by dilatation of distal superficial dermal vessels. And unfortunately, in seemingly too many cases, biopsies are simply non-diagnostic. Even with deeper sections, the profile is simply that of a dermal vascular thrombosis, and cholesterol clefts cannot be identified despite best efforts. Livedoid vasculopathy is characterized by the clinical presentation of distinct white scars known as atrophy blanche. Histologically, superficial dermal vessels are associated with fibrin, either in the lumen or obscuring the vessel walls. Occluding fibrin thrombi may be seen in the early stages of the pathologic process, with superficial vessels associated with fibrin cuffs, as shown in this example, courtesy Dr. Dan Lance, via our mutual slide trading club, with small superficial dermal vessels associated with fibrin cuffs and a sparse inflammatory background. Not only beneath areas of ulceration where secondary nonspecific vasculitic changes may occur, but also peripheral where the overlying epidermis is intact. And while the presence of intraluminal fibrin thrombi is relatively nonspecific, potentially compatible with virtually any form of coagulopathy or non-diagnostic embolic phenomenon, fibrin cuffs are relatively characteristic for livedoid vasculopathy. The histologic spectrum of septic vasculitis is somewhat similar to that of levamisole, with a tendency towards fibrin, thrombi, and vascular necrosis in a relatively sparse inflammatory setting. The key difference being, of course, that pathogens are present in the affected vessels. Generally not identifiable on routine H&E stain sections, but identifiable with gram stains, in this case, the gram-negative diplococci of meningococcemia. Ecthyma gangrenosum refers to septic vasculitis typically involving deeper portions of the dermis and subcutis, and usually involving gram-negative pathogens. The very high number of bacteria will present as a basophilic debris within and around the affected blood vessels, with gram stains typically identifying gram-negative rods, such as Pseudomonas aeruginosa or E. coli. Cutaneous collagenous vasculopathy is kind of a rare oddball vasculopathy. It's different from the other ones in that it's actually not characterized by fibrin thrombi, but rather it's a distinctive combination of a clinical presentation as generalized telangiectasia with biopsies showing superficial ectatic vessels with thickened hyalinized vessel walls that can be highlighted by markers for basement membrane material such as type 4 collagen or PAS stains. And ultrastructurally on electron microscopy, there are abnormally banded collagen fibers known as loose bodies. Full disclosure, the images that I'm showing here for illustrative purposes are not those of clinically confirmed cutaneous collagenous vasculopathy, but are shown here simply to depict the thickened hyalinized vessel walls that can be highlighted by the PAS stain. Truth be told, it seems to me that inflammatory vascular disorders could include really anything you want under the sun of inflammatory dermpath, but I will conclude here with a discussion of neutrophilic dermatoses and Wells syndrome. And it turns out that many of the other seemingly myriad list of diseases that others include under inflammatory vascular disorders, I actually have included in my lecture on perivascular dermatitis, so I'll refer interested learners to that lecture in the link shown. In my humble opinion, the key clinical and histopathologic features of Sweet syndrome are conveyed quite well by its synonym, acute febrile neutrophilic dermatosis. Histologically, we see a diffuse, superficial dermal neutrophilic infiltrate with nuclear dust and characteristically marked papillary dermal edema in the absence of vasculitis. The marked papillary dermal edema, readily apparent from scanning magnification, evokes a fairly short and specific differential diagnosis. If these cells are neutrophils, it's probably sweets. If there's lots of eosinophils, it's probably an arthropod bite reaction. If they're all lymphocytes, think about polymorphous light eruption, and it's not on acral skin, so this one is not perniosis. Although the neutrophilic infiltrates are classically superficial in classic Sweet syndrome, I noticed that this image shows some mid to deep dermal perivascular extension, which to me is a friendly reminder that there is a subcutaneous variant of Sweet syndrome as well. But back to the conventional classic profile, marked papillary dermal edema with secondary subepidermal separation, if only microscopically, is classic. And a second example with marked papillary dermal edema, but again extension into the deep dermis and subcutis, but with the balance of the infiltrate in the upper dermis. With numerous red blood cells surrounding blood vessels, in conjunction with neutrophils and nuclear dust, but no vasculitis. Worthy of mention is histiocytoid Sweet syndrome, which is a histologic variant characterized by larger histiocytic mononuclear cells whose nuclei are sometimes described as twisted and staining immunopositively for myeloid markers and histiocytic markers. And there does indeed seem to be an association between histiocytoid Sweet syndrome and having an underlying myelodysplasia. Some authorities have recently suggested that a subset of such cases might best be classified as myelodysplasia cutis. Pyoderma gangrenosum is a clinically distinctive neutrophilic dermatosis that is not infrequently biopsied to rule out other possible etiologies. The histopathology itself tends to be nonspecific, but at best will show a diffuse neutrophilic infiltrate, sometimes with a demonstrable undermining ulcer edge. And the Delphi consensus-based diagnostic criteria effort led by my colleague Emmanuel Mavrorakis has confirmed the utility of biopsy to exclude other causes, particularly infection, before accepting a diagnosis of pyoderma gangrenosum. Biopsies from clinically confirmed cases such as this one at best will show a diffuse neutrophilic infiltrate with evidence of an undermining ulcer edge, and the pathologist's duty is to reasonably exclude infection using histochemical stains. With higher magnification showing the ulcer edge and relatively diffuse neutrophilic infiltrates beyond the range that would normally be attributable to acute wound healing, and evidence of undermining at the ulcer edge, where the ulcer edge may appear hyperplastic or even pseudocarcinomatous. And we'll conclude with a review of eosinophilic cellulitis, which is an idiopathic condition characterized by cellulitis-like plaques with a relapsing and remitting course. The histopathology is quite distinctive for the presence of flame figures in the absence of vasculitis. Truth be told, although one should appropriately consider eosinophilic cellulitis whenever encountering flame figures, they can be seen in virtually any eosinophil-rich infiltrate, so the differential diagnosis is actually quite long. So long, in fact, that we'll finish by going full circle back to vasculitis in this case of EGPA that presented as bullous eosinophilic cellulitis with prominent eosinophils, but also extravascular necrobiotic granulomas, accompanied by flame figures which represent eosinophil granules deposited upon collagen fibers, and typically found in the context of a at least moderately dense dermal inflammatory infiltrate rich in eosinophils. In this particular case that presented as bullous eosinophilic cellulitis, there is papillary dermal edema and a partly re-epithelialized subepidermal blister, with the presence of relatively small flame figures and invariably prominent extravascular eosinophils, many of them continuing to degranulate and overtly, selfishly feeding their own flames